Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Associate Professor and HOD, Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we will be discussing about the various diseases related to the adrenal gland. Now, what is adrenal gland? What are the various hormones secreted by the adrenal gland? And what are the various disorders? All these things will be covered in this particular series of lectures. Today, we are going to discuss about adrenal gland introduction along with the Cushing syndrome. So, let us start with adrenal gland. Now, adrenal gland is basically a gland that is located above the kidneys. Each gland is weighing around 6 to 11 grams, and the adrenal comprises of several separate endocrine glands within a single anatomical structure. The adrenal gland can be divided into two parts. One is adrenal cortex and the second one is the adrenal medulla. The adrenal medulla is an extension of the sympathetic nervous system that secretes catecholamines into the capillaries. The adrenal cortex is made up of the cells which secretes cortisol and adrenal androgens and form a part of the hypothalamic pituitary adrenal axis. The small outer glomerulosa of the cortex secretes aldosterone that is under the control of the renin-angiotensin system. Now, the functions. The integrated control of the cardiovascular. Adrenal has an integrated control over the cardiovascular, metabolic, and immune response of stress. The adrenal cortex produces three classes of corticosteroid hormones. One is glucocorticoid, the other is mineralocorticoid, and the third one is the adrenal androgens, precursors. So we have glucocorticoids, we have mineralocorticoids, and we have adrenal androgen precursors. Now, first of all, the glucocorticoids. It is also known as cortisol. Glucocorticoids are responsible for the circadian rhythm. It is highest in the morning on waking and lowest in the middle and night. Cortisol rises during the stress, including any illness. The functions of glucocorticoid is the maintenance of cerebral glucose supply during starvation and inhibits potentially damaging inflammatory response to the infection and injury. The mineralocorticoids or the aldosterone, it binds to the mineralocorticoid receptors in the kidneys and causes sodium retention and increases the excretion of the potassium and protons. Catecholamines, only a small portion of the circulating noradrenaline or norepinephrine. It is derived from the adrenal medulla, which more is released from the sympathetic nerve endings. The adrenal androgens secreted in response to ACTH and are the most abundant steroids in the bloodstream, importantly in the initiation of puberty. Now let's discuss about ACTH or the adrenocorticotropic hormone. Adrenocorticotropic hormone secreting corticotrope cells constitute about 20% of the pituitary cell population. It is secreted in pulsatile manner and exhibits a circadian rhythm, peaking at around 6 a.m. and reaching a nadir at about midnight. The ACTH levels are increased by physical and psychological stress, exercise, acute illness, and insulin-induced hypoglycemia. The feedback regulation is through hypothalamus pituitary adrenal axis. The actions of the ACTH to maintain the metabolic homeostasis and mediate the neuroendocrine stress response. Normal ACTH level is 1.3 to 16.67 picomole. The normal cortisol level fasting 8 to 12 noon is 5 to 25 microgram per deciliter. 12 noon to 8 p.m. is 5 to 15 microgram per deciliter, and 8 p.m. to 8 a.m. is 0 to 10 microgram per deciliter. Now, the deficiency of ACTH. Due to secondary adrenal insufficiency as a result of pituitary ACTH deficiency, it is characterized by fatigue, weakness, anorexia, nausea, vomiting, and occasional hypoglycemia. For the diagnosis of ACTH deficiency, lab tests are done, which includes low ACTH levels, low serum cortisol levels. The treatment includes the glucocorticoid replacement therapy and prednisolone 5 mg in the morning. Now let's start with the Cushing syndrome. Cushing syndrome, or it is also known as ACTH-producing adenoma. The etiology of Cushing syndrome includes pituitary corticotrope adenomas, iatrogenic hypercortisolism, ectopic tumor ACTH production, cortisol producing adrenal adenomas, adrenal carcinoma, and adrenal hyperplasia. Cushing syndrome is prevalent in around 10 to 15% of all with pituitary tumors. 5 to 10 times more common in women than in men. So, Cushing syndrome is common in females as compared to males. Now, the clinical features. In the clinical features, adrenal gland, Cushing syndrome, the skin becomes thin. There is central obesity with hypertension. There is plethoric moon phases, purple stria, and easy bruisability. The glucose intolerance or diabetes mellitus is present with gonadal dysfunction, osteoporosis, proximal muscle weakness, and signs of hyperandrogenism, which includes acne and hirsutism. Psychological disturbance like depression, mania, and psychosis are present in the patient. Now, the differential diagnosis. Cushing syndrome has to be differentiated from simple obesity, PCOS, and chronic alcoholism. With simple obesity, there is no characteristic fat distribution. In obesity, and thin skin and proximal myopathy is seen in case of Cushing syndrome. With PCOS associated with obesity and hirsutism, no features of cortisol excess and skin is thick. In chronic alcoholism, the history of chronic alcohol consumption is found and other features of liver disease. There are various hemopoietic features which includes leukocytosis, lymphopenia, and eosinopenia. Immune suppression includes delayed hypersensitivity and infection propensity. In the lab investigation, measurement of 24-hour free cortisol level is done. Mean basal ACTH levels are 8-fold high in patients with ectopic ACTH secretion than those with pituitary ACTH secreting adenomas. In case of Cushing syndrome, various imaging techniques are used, which includes pituitary MRI to detect microadenoma, chest radiograph for ectopic ACTH syndrome, most tumors in the thorax, and CT scan of adrenocortical tumors are easily viewed. Now, the treatment of Cushing syndrome. For the treatment of Cushing syndrome, selective transsphenoidal resection can be done. After successful tumor resection, most patients experience post-operative period of sympathetic ACTH deficiency that may last up to 12 months. This is actually requires low dose of cortisol replacement, pituitary irradiation after unsuccessful surgery, but cures only 15% of the patient. Metiperon normalizes plasma cortisol in around 75% of the patient. So this was all about Cushing syndrome. In the next lecture, we will be starting with hypoaldosteronism or Conn syndrome. I hope you must have understood the session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.